Bismillahirrahmanirrahim. So now we are starting with the fifth chapter of BD Terracea upper limb, that is back. So what happens over here is we are going to discuss certain surface landmarks. So scapula. So this shoulder blade is scapula. It is from the second to the seventh rib. And then they are saying the eighth rib. So the eighth rib is just below the inferior angle. So here is the inferior angle. Below the eighth rib, we have below the inferior angle of the scapula, we have the starting point of eighth rib. Then we have the iliac crest. This upper part of the hip bone, which you can feel when you put your hands on your hips, is known as the iliac crest. It is very much important because it is the area from where we take bone marrow for bone marrow biopsy processes. Then we have the sacrum. So this bone, which also sometimes we call this tailbone, that is the sacrum. This upper part of this tailbone becomes the sacrum, and lower part of this tailbone, it is the coccyx. It is between the two buttocks in the natal cleft or in the median plane and spine of the seventh cervical vertebra or the vertebra prominence. Let me show you. So at this point, at this lower point of your neck, we have the spine of the seventh cervical vertebra or the vertebra prominence, below which we get the thoracic vertebra started. So from this is a C7. From hair point to hair point, we will have T1 to T12 or the thoracic vertebra, and then this will become the L5, the lumbar vertebrae. Then this point is very much important because this is the external occipital protuberance. This is the external part of your occipital bone in your skull. So we human beings, we lie on our back. So what happens? The back is maintained, or back is made in such a way to maintain or support this pressure, as a result of which we have a large number of layers on the back. We have fascia, we have superficial fascia, which has fat, it is thick and strong, and it is covered by skin and by the connective tissue, and we have deep fascia, which is dense in structure. Now we have cutaneous nerve. All the nerves of the back, except for the C7 vertebra, C1, C7, C8, L4, L5, these do not give off any cutaneous branches. All the other except these, they give off cutaneous branches, and their posterior primary ramus supply the areas of the back. So here they are showing this is a spinal nerve which is coming, and it has two portions, which is the ventral ramus and this is a dorsal ramus, and each dorsal ramus is further divided into one lateral branch. This one is lateral branch and this one is the medial branch. So they are saying that posterior or dorsal primary ramus divides into medial and lateral branches. So we have this lateral branch, this medial branch, and this was the dorsal one, and this was the ventral primary ramus. So this was explained. So the posterior primary ramus, here it supplies the posterior muscles of the back or intrinsic muscles of the back. No posterior primary ramus ever supplies the skin or muscles of a limb. So it supplies the intrinsic muscle of the back but does not supply the skin or the muscles of the limb. That is, the posterior ramus are not going to give any branches to your hands or to your arm or to your legs. They are going to give cutaneous innervation to the back of your area or the intrinsic muscles like the trapezius muscle, the serratus muscle, etc. So we are going to start with our first ever muscle, which is the trapezius muscle of the back. So it will have its origin from this superior knuckle line, this knuckle ligament, this vertebra prominence or the C7 vertebra, and T1 to T12 thoracic spines. So this will be the origin. The superior knuckle line, the knuckle ligament, C7 vertebra, and T1 to T12 all the vertebrae. And the insertion is going to be the posterior side of the lateral one third of the clavicle, because the muscle is on the posterior side. So we will say it is going to be on the posterior side of the clavicle, and it is going to be on the lateral one third, whereas the medial border of the acromion process will give insertion to the trapezius muscle. So these two areas are insertions, whereas these two areas are origins. And as we know that the origin is pulled toward the insertion. So this upper area, these upper fibers, these descending fibers, because they are moving downwards, so we will call them descending fibers. What they will do, they will elevate the trapezius muscle. These lower fibers, they are moving upwards, so they are ascending fibers. So what they will do, they will work with these ascending fibers, these ascending ones, these ascending, the downward moving upwards, these ascending one and these descending ones, they will combine together and they will produce the movement of rotation. Firstly, it was on its alone, on its own, these descending ones were providing the movement of upward, that was elevation, whereas descending and ascending combined together, they were producing the movement of rotation. Now these fibers, the middle one, they were producing the movement of retraction of the scapula. So we get elevation, retraction, and combined together we get rotation of the scapula by the trapezius muscle. And this trapezius muscle is supplied by spinal accessory nerve number 11. So this muscle over here, this muscle is the latissimus dorsi muscle. We will look at the origin and insertion of this muscle. First of all, its origin is from the inferior angle of the scapula. Then it is going to have an origin from the T7 to L5 thoracic or lumbar spines. Then it is going to have an origin from thoracolumbar aponeurosis or fascia. Then from iliac crest. So scapula, iliac crest, the T7 to L5 spines, and the thoracolumbar fascia. This will be the origin, whereas the insertion will be on the bicipital groove or the intertuberculous sulcus of humerus, or the floor of the intertuberculous sulcus of humerus. What will it do? The main function of this one is to pull the origin towards insertion. So it will do extension, it will move the humerus away from the body, it will do medial rotation, that is towards the midline of the body. Then it will do adduction, that is this humerus will move towards the body. This movement is known as adduction, and medial rotation is a rotatory movement towards the body, whereas extension is away from the body, movement away from the body. It is supplied by the thoracodorsal nerve or nerve to the latissimus dorsi, and the nerve supply is C6, C7, and C8, or nerve to the latissimus dorsi, also known as thoracodorsal nerve. So now we have this levator scapulae muscle. It is having origin from transverse process of C1 to C4 muscles, C1 to C4 thoracic, sorry. So it is having its origin from C1 to C4 cervical vertebrae, insertion on the superior angle of the scapula. So it will pull the insertion towards the origin. That in such a situation, what will happen? It will raise the scapula. Levator scapulae, it will raise the scapula or elevate the scapula and rotate the scapula. Simple as that. Levator or elevator, you can say it, elevator muscle of the scapula, and it will be supplied by dorsal scapular nerve. So now we have the rhomboid minor and rhomboid major muscle. This one is the minor muscle, this one is the major muscle. So rhomboid minor is having its origin from the spinous process of the C7 and T1 vertebrae, insertion on the medial border from the upper area towards the spine. Then second part is rhomboid major. This is having its origin from T2 to T5 thoracic vertebrae, having its insertion from the root to the inferior angle on the medial border of the scapula. supplied by the same nerve as that of levator scapulae, that is the dorsal scapular nerve, and it retracts the scapula. Rhomboid, as the name suggests, or it is starting from R, so you can remember retraction of the scapula. Other thing is rotation of the scapula. So retraction and rotation, both of the words are coming from the name of the muscle, that is rhomboid. So I have taught you all of the muscles: the trapezius muscle, the latissimus dorsi, levator scapulae, rhomboid minor and major, through the diagrams. And if you will do the diagrams that I've shown you, you will get to know that it is very, very easy to remember the functions and the origin, insertion, and blood supply or nerve supply of these muscles. One important thing that you need to know from this chapter is that the spine of the scapula, the root of the spine of the scapula, will have a bursa over it, and sometimes that bursa might get inflamed. That is why it's very important to know that the root of the spine of the scapula will have a bursa on it sometimes. Now we have this triangle of auscultation. Let me help you learn this one via a diagram as well. Now we come to this very beautiful area on the posterior side. This is the triangle of auscultation, bounded medially. This medial side is by the lateral border of the trapezius muscle, laterally by the medial border of the scapula, inferiorly by the upper border of the latissimus dorsi muscle. This is the triangle of auscultation. There will be two ribs present over here, the sixth rib and the seventh rib, and the intercostal space between them will be the sixth intercostal space. Now the respiratory sounds of the apex of lower lobe of the lung are heard via a stethoscope in this area. On the left side, cardiac orifice of stomach lies deep to the triangle, and esophageal tumor can also be detected via this triangle of auscultation. Esophageal tumor is there. We can also hear respiratory sounds, and the orifice of stomach also lies deep to this triangle. Now we have lumbar triangle of petit. Let me show it to you. So we have this diagram to visualize the lumbar triangle of petit. So this area is a lumbar triangle of petit. It is formed medially by the lateral border of latissimus dorsi. It is laterally formed by the posterior border of external oblique muscle. Inferiorly, it is formed by the iliac crest. The occasional hernia at this height might be the lumbar hernia. After completing dissection of the back, the limb with clavicle and scapula is detached from the. That is very thing that is related to the dissection. So it was the place of lumbar hernia, whereas the triangle of auscultation was the area where we could hear respiratory sounds. We could palpate the esophageal, the stomach orifice, as well as we could see the esophageal tumor at that place. So we are done with this. Now let us go to clinical anatomy. So they are saying a poor young adult felt multiple nodules in the region of his neck above the clavicle. A lymph node biopsy was advised from the right side of his neck. A few days after biopsy, he was unable to shrug the right shoulder. Why was the biopsy advised, and why is he not able to shrug the shoulder? So as we know, the shrugging of the shoulder is the work that is done by the trapezius muscle, and trapezius muscle is having nerve supply from the spinal root of 11th nerve. So when the spinal root of 11th nerve will get injured, the trapezius will not be able to perform its shrugging action. Now they are asking about boundaries of the triangle of auscultation. So we know the triangle of auscultation, it is formed by latissimus dorsi on the medial side, on the lateral side by medial border of the scapula, and on the inferior border it is formed by latissimus dorsi. Medial one was formed by trapezius. So which one will be the odd one out? Lateral border of trapezius, it is involved or not? No. Medial border of scapula? No. Because they are a part of this. Upper border of latissimus dorsi? Yes. The lateral border of trapezius is over here. Medial border of scapula on the lateral side. This inferior part is formed by upper border of latissimus dorsi. So odd one out is upper border of teres major. It was not even involved in the triangle of auscultation. Boundaries of lumbar triangle of petit, which was formed by iliac crest on the inferior side, external oblique muscle on the lateral side, and medial side was by latissimus dorsi. So, quadratus lumborum will be the odd one out one. Trapezius is not attached to. It was attached to clavicle. It was attached to occiput. It was attached to scapula, but it was not attached to first rib. So, 3B. Posterior primary ramus of which of the following nerves give cutaneous branches? We know C1 won't give, C7, C8 won't give, L4, L5 won't be giving, so S1 will be giving the branch. These ones, they were the ones which will not giving the branches, so S1 will be the one which will be giving branches. Which structures does not lie deep to the trapezius? Spinal accessory nerve, the superficial branch. The structure one is the branch of transverse cervical artery. The transverse cervical artery, it is not lying in the trapezius actually. It is lying very superficial, that we will study in the anastomosis around the scapula. That one is related to some other chapter. We are done with this chapter. I hope you understood everything related to back of your upper limb. Thank you very much. See you in another video.